The Naloxone training, kick things off with a nice morning warm-up. So we're going to have Dave Kispert come up and lead that off.
My name is Dave Kispert. Before beginning my talk, I would like to express my gratitude for being selected for such an honor. To the entire staff of the India Street Needle Exchange, thank you for sharing your work, which is truly free of judgment and filled with hope. In particular, I would like to thank Zoe, whose relentless compassion and commitment to improving the lives of some of our most marginalized community members has been an inspiration. I have the privilege of beginning this inaugural event with a brief talk on opioid overdose and what we, as care providers and concerned residents of Maine, can do to reduce the incidence of this completely preventable condition. I hope to equip you with the essential information to understand opioids and associated overdose risks, respond to an overdose, and empower you to improve the distribution of naloxone, a life-saving medication that combats opioid overdose and embodies the power of the harm reduction movement. Please keep in mind this is not just applicable to people who inject drugs. Any individual that takes opioids, whether prescribed or obtained illicitly, is at risk. This is a beautiful slide created not by me that showcases the flowering opioid poppy plant for which opiates such as morphine are directly derived. Opioids work by binding specific receptors in the brain, spinal cord, and GI tract, resulting in diminishing the body's perception of pain. They include prescription medications used to treat pain, such as oxycodone, hydromorphone, as well as illicit drugs such as heroin. Binding of any of these opioids to the opioid receptor can not only cause the euphoric effects or high with use, but also the signs and symptoms of overdose. I will not belabor the individual differences of these drugs, but please note the variability among opioids and their duration of action and potency. Drugs with high potency, such as fentanyl, require a smaller amount of drug to produce a certain level of effect. These higher potency drugs make individuals much more susceptible to overdose, as it takes much less of the drug to cause the deadly symptoms. Overdose occurs due to the effect of opioids on the part of the brain that regulates breathing. In high doses, opioids can cause respiratory depression and subsequent death. It is experienced by all individuals, regardless of age, gender, ethnicity, or socioeconomic status. There are a number of factors that increase the risk of overdose. Individuals build tolerance to the effects of opioids. With consistent, repeated exposure to the drug, more drug is required for the same effect. When the amount of drug used decreases or increases, individuals stop using opioids, this tolerance fades. It is well known that upon release from prison, individuals that lacked access to opioids while incarcerated frequently use in amounts for which they had previously built up a tolerance prior to their imprisonment. This puts them at tremendous risk of overdose. The state of Rhode Island recently initiated laws enabling prescription of medications for addiction treatment, that's Suboxone and methadone, in the prison system, which has resulted in an actual reduction in overdose deaths over the past 2 years, which is unheard of right now in the crisis that we have. This singular change was seen as a key contributor. Mixing of other drugs with opioids significantly increases the risk of overdose and death, particularly alcohol and benzodiazepines, which are anxiety-reducing medications that in high doses also cause respiratory suppression. These common brand names include Xanax, Valium, and Klonopin. Drug mixing accounts for nearly 9 out of every 10 opioid overdose deaths. Not surprisingly, prior overdose is a major risk factor for overdose deaths and produces a 6-fold increase in subsequent overdoses in the next year. The current lacing of the heroin supply with fentanyl, a more potent opioid, has caused clusters of overdose deaths among people who inject drugs. If you inject drugs, have friends or family who inject, or work with individuals who inject, this advice can save lives. Whenever possible, know your supplier and your supply. Learn how to inject yourself so you can know your own limitations. If possible, switch to a different route of administration, such as snorting or smoking. Try a test dose before using an entire shot. Never use alone. Without a friend to respond, you are at a substantially higher risk of death if you do overdose. To combat overdoses related to fentanyl lacing, there is an exciting new development in the form of fentanyl test strips, which will allow users to test a product for the potent substance prior to use. By attending this conference, you each have taken up the banner of harm reduction advocacy in your communities. As most, if not all of us, are trained in basic life support measures, we must familiarize ourselves with the steps to respond to a suspected overdose. SAMHSA, the Substance Abuse and Mental Health Services Administration, has created an overdose prevention toolkit available online that includes these 5 essential steps for first responders. These steps include evaluate for signs of opioid overdose, call 911 for help, administer naloxone, support the person's breathing, and monitor the person's response. Let's go through these steps one by one. We need to know what to look for with an overdose. Individuals are unconscious, unable to awaken. They exhibit slow or shallow breathing. You may hear choking or gurgling. Pay attention to an individual's fingernails or lips as they may change purple or blue. If you encounter an individual with these symptoms, you need to try to rouse them. You can start by calling out their name. If no response, grind your knuckles into their breastbone. It causes discomfort, but it doesn't cause significant harm and is an effective means to awaken the individual. If the person responds, assess whether he or she can maintain responsiveness and breathing. Continue to monitor the person, including breathing and alertness, and try to keep the person awake. No, missed a slide there. If no response, call 911. Get right to the point. If someone is unresponsive and not breathing, and provide specific location details to get EMS dispatched. Step 3 is administer naloxone. I'll go into a little bit of detail about the medication itself. Let's see. Also known as Narcan, the opioid antagonist will kick out the offending opioid off the receptor, reversing the effects of the opioid, including respiratory suppression. It is a safe antidote for all opioid overdose. There is no risk of abuse, no dependency in its use. If and when an overdose is suspected, naloxone should be administered. Apologies for the typo. It says expected up there. We would never want an expected overdose, only a suspected overdose. Important to note that Good Samaritan laws provide immunity to anyone who administers naloxone. There are 4 formulations of naloxone. People receiving naloxone kits pictured on top should receive brief training on assembly and administration. It is not currently FDA approved, but still covered by some insurances, such as Maine Free Care. The FDA has approved an injectable naloxone, an intranasal naloxone, and a naloxone autoinjector as emergency treatments for opioid overdose. The nasal spray is a pre-filled, needle-free device that requires no assembly and can deliver a single dose into one nostril. The autoinjector is injected into the outer thigh to deliver the medication. Naloxone's duration of action lasts anywhere from 30 to 90 minutes. As many opioids exhibit a longer duration of action, the naloxone may leave the body before the opioid does. This means even if the patient responds to the initial dose of naloxone, another dose may be needed later on. The goal of naloxone is the restoration of breathing. This is accomplished by displacing some, but not all opioids from the receptors. Achieving a complete arousal will create an unnecessary and uncomfortable withdrawal state. Regarding its safety, naloxone will have no effect on individuals that are not taking opioids. As mentioned before, it can precipitate very unpleasant withdrawal symptoms. Using the smallest dose of naloxone can minimize this chance. It is a Category C medication that risk in pregnancy cannot be ruled out. However, in life-threatening circumstances, it is advisable to administer the medication to pregnant women. Regarding its storage, it should be stored in a safe and accessible location. It should be left at room temperature and protected from sunlight. Make sure to check your expiration date. Step 4 is supporting the person's breathing. The steps for this include ensuring airway clearance, performing the head-chin tilt, pinching the nose, creating an adequate seal around the person's mouth. A good improvisational barrier device comes in the form of a t-shirt. Give 2 slow breaths, watching for chest rise, and repeat the process every 5 seconds. The final step is monitoring for the person's response. Most people respond to naloxone with return of spontaneous breathing. This occurs 2 to 3 minutes after naloxone administration. This can feel like a long time. In the heat of the moment, you may feel an urge to give more naloxone. Wait, and if possible, keep a timer. there's not a response after those 2 to 3 minutes, administer a second dose. As mentioned before, overdose symptoms can recur after naloxone wears off. Having a formal medical assessment is critical in any overdose response. Following return of breathing, the recovery position pictured here may be used to place the person in a safe position while awaiting for EMS to arrive. This includes turning the person's face and body on his or her side, placing a hand underneath the individual's head, and bending a knee to support the body. Naloxone can precipitate an opioid withdrawal state that can be very unpleasant. The symptoms run from mild discomfort to severe pain. Individuals previously on high-dose opioids with sudden discontinuation have described the symptomology of withdrawal in gruesome detail. These symptoms are not life-threatening and will wear off over time, but in the true spirit of harm reduction, we hope to minimize these unpleasant symptoms by administering the lowest necessary medication dose while accomplishing the obvious priority of saving lives. In summary, a few do's and don'ts. Do attend to the person's breathing through rescue breaths. Chest compressions are indicated if the patient does not have a pulse and should be performed through the basic life support algorithm. Do administer naloxone. Do put the person in the recovery position, and do stay with the person and keep them warm. Leaving the patient alone, putting them in a bath, inducing vomiting, or injecting them with anything besides naloxone exposes them to undue risk. Some key points for first responders. Be gentle and comforting to the individual as they wake, taking care to explain what happened. Discourage individuals experiencing withdrawal symptoms from taking more opioid, as this can induce another overdose. Naloxone is only effective against opioid overdose. It is not effective for benzodiazepines, barbiturates, cocaine, or amphetamines. If opioids are taken in combination with other drugs, administering naloxone can be helpful. How quickly an overdose occurs following opioid use depends on the drug. Long, not low-acting opioids may have a delay in overdose symptoms of several hours, while fentanyl may produce overdose in just a few minutes. Layperson use of naloxone from individuals such as yourselves has been associated with fewer withdrawal symptoms than administered by paramedics. This is no slight against our professional first responders who are true champions in this opioid crisis, but lends credence to the fact that we are all capable of responding to an overdose. Although there is the occasional person who responds to naloxone in an agitated withdrawal, this is in fact a very rare occurrence, happening less than 5% of the time. I'd like to finish the talk with a brief summation of issues related to access and distribution of naloxone. It has been researched that it takes 164 prescriptions of naloxone to save one life. Some evidence even suggests it may take as few as 36 prescriptions to save one life, as having naloxone also encourages safer use. When considering that it takes 42 prescriptions of aspirin to prevent one heart attack, it seems prudent to increase the rate of naloxone distribution. For the future physicians and pharmacists in the audience, the CDC produced guidelines for opioid prescribing back in 2016. Woven within are 12 basic tenets of opioid prescribing that I and most of my colleagues were initially unaware of. One of these rules includes consideration of naloxone prescription to individuals deemed high risk for overdose. These include those taking a high-dose opioid for greater than 3 months, concurrent benzodiazepine use along with opioid use, a history of any substance use disorder, and a history of overdose. With the guidance of Dr. Keena Thakrar, who will be presenting later today, we evaluated local area clinics for compliance with this largely unknown recommendation over an 18-month period. The results were striking. In the studied clinics, we found over 2,000 patients that met at least one of these criteria. A total of 17 patients were prescribed naloxone for a less than 1% compliance rate. In comparison, the Needle Exchange distributed over 2,000 naloxone kits in the 2017 year alone. This is no fault of our physicians, as I will explain barriers to treatment. To the future healthcare providers in the audience, I urge you to consider this treatment gap and incorporate naloxone prescribing into your future workflows. You will truly be ahead of the curve. Let's not forget other individuals that can benefit from a naloxone prescription. People who inject drugs are of obvious concern. Family members and friends of individuals on chronic opioid therapy, as well as individuals serving high-risk populations in a shelter or soup kitchen, may find carrying naloxone particularly beneficial. Now the barriers. I focus on intranasal naloxone as it's the most common formulation being prescribed in the healthcare setting. The cost is prohibitive for all too many individuals. Out-of-pocket costs, forget it. Certain insurances such as MaineCare and Harvard Pilgrim provide monthly prescriptions, which is fantastic. On the other hand, convincing a patient to shell out $40 for medication that many believe they don't need is a substantial hurdle. Just as challenging is educating patients on the benefits of naloxone. The word overdose alone can garner a sense of irresponsible use and be off-putting to patients. Instead, language such as accidental overdose, bad reaction, opioid safety can be more palatable. Explaining an overdose in simple terms is crucial. Opioids can slow your breathing. Naloxone is an antidote to opioids. Naloxone is for opioid medications like EpiPen is for someone with an allergy. My personal favorite is the simile to a fire extinguisher. Just like homes have a fire extinguisher in case of a fire, people can carry naloxone in case of an opioid overdose. Expanding access to naloxone and other harm reduction services is crucial to the health of our Maine community. As election season reaches its climax on November 6th, I urge you all to go out and vote for the change you wish to see and contact your local legislatures. The needle exchange does so much with so little and needs funding. We have an evidence base for how medications for assisted treatment in the prison system reduce overdose deaths, but it's not implemented here in Maine. These changes in Maine will only come through advocates such as yourselves. I did not share the exciting new legislature on pharmacy-based naloxone prescribing because there is so much confusion and disparity among the pharmacists that I work with that it's very challenging that there's really no good law in place right now or standard of practice. For future pharmacists, I urge you to pursue simplified legislation and complete the 2-hour naloxone certification. For future doctors in the room, there's a terrible shortage of physicians certified to prescribe Suboxone, a tried and true medication for opioid use disorder. Please consider undergoing the 8-hour X-waiver training when you enter residency. If you want more training in addiction in your school curriculum, let your leadership hear about it. I thank you all for sharing your time with me. I'll be available throughout the day and later this afternoon hope to be sending out and writing naloxone prescriptions for all interested parties. Thank you.